Hello, everyone. Thank you for attending today's webinar, Not If, But When, Scaling the Impact of a Remote Patient Management Program, presented by Bioformis. I'm Joan Wiseman, and I'll be introducing our panel and covering a few housekeeping items as we get started. Our panel today is Adam Updegraff, who's the Clinical Director for WellSpan Health, Jen Mann, who's the Senior Innovation Manager at Healthcare Transformation Lab with Massachusetts General Hospital, Daryl Dow, who's the Executive Director of the Center for Virtual Health at Christiana Care, and Rachel McIntosh, who is the Senior Vice President of Clinical Operations for Bioformis. A few housekeeping items as we get started. You can read their full bios on the left side of your window by selecting the Speakers tab. To access handouts, additional resources for today's presentation, click the Handouts tab at the left side of your screen, and you can download some handouts there. You can access closed captions from the bottom right corner of the video player, if that's helpful. This webinar is being recorded, and you will have access to watch it on demand within 24 hours after we complete today's program. And we would love to hear from you. During the presentation, feel free to submit any questions you have using the Questions and Answers tab at the left side of your screen. Time permitting, we will include as many questions as we can at the end. Thank you again for joining us. I'll turn things over to Jen Mann, who will be moderating today's discussion. Jen.
Thank you, Joan. It's great to be with you all today. My name is Jennifer Mann, and I am an engineer by trade and a technology advisor to Mass General Hospital's Hospital at Home program. And so as an advisor to MGH's Hospital at Home program, I've had the pretty awesome opportunity to work closely with the clinicians and the leaders there who have built and grown one of the most successful remote care programs in the US. In fact, MGH has been able to scale their program and deliver care to over 1,500 patients at this point. And we currently have a 12-bed unit that is rapidly expanding. So as a result, the hospital has delivered care and improved outcomes with fewer admissions and much lower reduced costs of care. And that's why today I'm really excited to have this opportunity to learn about the experience and the outcomes of other programs. And I'm delighted to facilitate today's discussion. I'd also like to just quickly thank Bioformis and Fierce Healthcare as well for sponsoring and hosting today's session. So without further ado, I will let each of our esteemed panelists introduce themselves and their organization, and then we will dive into this topic some more. So Adam, why don't you start us off?
Thank you. My name is Adam Updegraff. I am the Clinical Director for Continuing Care Services within WellSpan Health, located in central Pennsylvania. We have 7 acute care facilities across 6 counties in central Pennsylvania. I am a doctor of prepared nurse practitioner by trade and hospitalist trained on the medical side, and I've been in this role for about 3 years now.
Wonderful. Thank you, Adam. Daryl, would you like to go next?
Sure. I'm Daryl Dow. I'm the Executive Director of Christiana Care Center for Virtual Health. Christiana Care is the largest health system in a small state up in northern Delaware. We have 3 hospitals, soon to be 4. And just a wide variety of services. I manage our technology and analytics teams at the center, so that is my primary function. I'm a computer scientist by training, and I also teach as an adjunct at Wilmington University, teaching analytics for healthcare professionals.
Great, thank you, Daryl. Really looking forward to hearing more about Christiana Care's experiences. And then last but not least, Rachel, if you would like to tell us a little bit about yourself.
Sure. Rachel McIntosh, SVP of Clinical Operations at Bioformis and also CAO of our medical practices. Bioformis is an international organization, and we work in all levels of remote care in hospital at home, post-acute, and chronic care. And we're licensed to practice medicine in several states through our medical practices. I'm a nurse by my background. I've been with Bioformis for about 2.5 years, and I'm really looking forward to hear what the other panelists have to say as well. Thanks.
Great, thank you all. All right, so why don't we kick things off? So today's session is all about scaling the impact of remote patient management. So the terms remote care and RPM can cover a wide spectrum of care delivery. So to give us some context, can you each tell us what experience your health system has had to date with delivering remote care in the home? And Daryl, do you mind kicking us off?
Sure. So virtual health has been happening organically at Christiana Care for years. But obviously, as a shared experience for all of us, the pandemic really sped that up and gave us a focus towards really formalizing that role. And to that end, we've spun off the Center for Virtual Health, which is a wholly owned subsidiary, really focused on two big ideas. One being that the home is the new venue of care, and the other being that everything that can be done virtually will be done virtually as we move forward in our health system. So under the direction of our Chief Virtual Health Officer, Sharon Anderson, we've spun out a couple of hubs to provide care in different ways. We have a hospital care at home program that's out of our acute hub. To date, we've had about a little over 550 patients. That's been running for a year and a half. So really ramping that up and driving towards a larger average daily census. We're hoping to about double that over the next year. Right now we're sitting at about 11, and we're hoping to be around 25 a year from now. That's an aspirational goal, but we think we're going to get there. So that's the one hub that we're running. The other hub is our virtual primary care hub. It's a completely virtual primary care practice. We have about 1,500 lives attributed right now. And we provide all of that care virtually to folks. We're a big proponent of alternate payment models, so we have a lot of different types of things going on there: direct to employer, direct to consumer, partnerships with payers, and so on. So a lot of things happening in the virtual space at Christiana Care right now.
Great, thank you for sharing that. Yeah, and great to hear about those ambitious plans to double the census. We'll have to see who gets there first, right? Some healthy competition. And so Adam, same question to you. Can you tell us about your experience with your health system, or the experience that your health system has had to date with delivering remote care in the home?
Yes. So our remote patient monitoring program started out about 6 years ago. It was focused on, patients with specific diagnoses, and it has evolved into not necessarily diagnosis driven, but more so services that we can provide safely in the home, creating access, and even focusing on mental health and social determinants of health. Under our umbrella and continuing care services, we developed a practice and slid about 3 years ago, remote patient monitoring under WellSpan at Home. So now we have Hospital at Home that I developed and launched in September of 2020. That's been going strong, going on 3 years now, and served almost 2,000 patients, saving our healthcare system over $2 million in bed capacity days alone. And then we also have an advanced illness management program where we virtually see patients for palliative or chronic disease management from their home. And this is launched through our WellSpan Visiting Nurse Association. So the nurse is in the home with the patient. And to date, we've seen over 2,500 of those patients. And then we also most recently added our primary care at home, where we're virtually or in person seeing patients, where there's some social determinant of health or access issue to being able to get into primary care services. So once a patient falls in any portion of this umbrella, we can swing them back and forth across the care spectrum, and also integrate them into partnerships we have within hospice organizations or other entities that they might need within WellSpan.
Thank you, Adam. Yeah, great to hear that you're expanding that remote care into so many different programs and departments. And so Rachel, so I know Bioformis obviously partners with healthcare systems to deliver remote care. So can you give us some examples of use cases?
Of course. So Bioformis has developed one platform that covers the entire care continuum called Care at Home. And so some use cases, as an example, we can work within the hospital at home realm, in the post-acute or timely discharge realm, or in the chronic care realm. So taking a use case from a hospital at home, we can manage the patients from the admission through the entire stay for the patient up until discharge, and then transition them to that timely discharge and or post-acute program where we can continue managing that patient without changing any of the equipment, technology, or tools that the clinicians are using. Following that same thread, once that patient finishes the post-acute phase and they're out of the risk for readmission, they can be transitioned again, same platform, same tools, to a chronic care program where their diseases can be managed on an ongoing basis. So you take that from the health system perspective, that use case is simple, set it and forget it, set them on the Bioformis platform, and they are managed from end to end. And similarly, from a patient perspective, they don't have to relearn equipment, meet a new clinical team, or have additional technology shipped to their home. Everything is all in one. So that's a end-to-end use case for you.
Wonderful. Thank you, Rachel. Yeah, and I know from it's great to hear how you guys have consolidated so much of the technology and the telemedicine and the clinical team coordination into one platform. Because I know from my experience in being an advisor to MGH's home hospital program, not every patient is the same. Different patients might need different technology, different amounts of technology, and we can't have clinicians pulling up multiple apps and responding to alerts and communicating with clinicians on multiple different devices. It's just not efficient, especially if we want to scale, right? So it's great to see all of this come into one plug and play platform. So going back to you, Adam. So can you remind me, did WellSpan receive the CMS waiver for the acute care at home program? Yep.
We did.
And so what advice would you give to those who are considering deploying a new hospital at home program? It's a big question.
Do I have an hour for that answer? No, I'm kidding. way back in the pre-pandemic era, where planning was taking place, we sought guidance initially from our Pennsylvania Department of Health of where this program should lie, and we were instructed to do it in the outpatient ambulatory space. As everything kind of evolved and we launched, CMS came out with their acute hospital care at home waiver, which we applied for and obtained at 3 of our 7 acute care hospitals that were the busiest at the time and that we could staff those entities. Since then, CMS has come out with the waiver extension through December of 2024, but our Pennsylvania Department of Health is having us apply for an exception after the PHE ended back in May. So we are currently in a pause phase with our waiver, waiting for the exception to come through to continue to utilize it through December of 2024. So my biggest recommendation is know your state regulations, know your federal regulations, make sure your state is endorsing them. If not, advocacy is the key. And I'm very thankful to work for an organization that has a lot of senior leaders that are advocating for hospital at home at the state level. We've had lots of meetings with state representatives and senators. We had a new governor come in this year as well. So lots of advocacy took place to make this happen.
Great. Thank you for consolidating that 1 hour response into a minute. That was great. And so Daryl, similar question to you. What advice would you give to some new hospital at home programs?
Yeah, I would echo all of the things that were just said, but I would also throw in there that, a lot of the times we get focused on the technology platform and reaching out and, how do we connect patients to care and so on. There's a lot of the same challenges that you have in a regular traditional brick and mortar hospital care at home. There's logistics and there's scheduling. And you need systems that are kind of a little bit better than sticky notes on a whiteboard in order to manage some of those challenges. You're diversifying some very things that used to be down the hall are now across town, right? We are in a geographic region where we have multiple states around us, and being aware of your state regulations is very important. New Jersey is not the same as Pennsylvania, is not the same as Maryland. So right now our efforts are in hospital care at home really are inside the borders of Delaware. As we seek to, and we're expanding into those other places, we have to make haste carefully and cautiously. So just understanding the full scope of what you're setting up, you're starting an honest to goodness hospital. And you really have to think about all the various things that go into that.
Great. Thank you, Daryl. So it looks like we lost Rachel for a moment, so we'll see if she comes back. But so Adam and Daryl, so on December 23rd of last year, the CMS waiver fortunately was extended. But of course, that just means that now a new countdown begins, right? And here we are with 18 months left. So how is your health system viewing this new looming deadline? Adam, do you want to go first?
Sure. So I don't think we really view it as a looming deadline, because at the end of the day, even with the CMS waiver, we'll still have two arms of our program, in essence, the inpatient and outpatient arm. The only downside is our reimbursement and payer agreements that we're all working to obtain on the inpatient arm. So reimbursement will be the biggest doom and gloom if something in permanent state is not extended at the federal level. WellSpan was very, this was a pandemic. We needed to do the right things for our patients and the communities we serve. And the ambulatory arm of this program is not profitable whatsoever. We're really only billing like a outpatient practice would be billing. So being able to set up those agreements on the inpatient arm is what really keeps programs like this afloat. And without that, I think a lot of programs will struggle across the country.
Great, thank you. And Daryl, same question to you.
Yeah, absolutely. So, I mean, there's no doubt that, especially the hospital care at home space, Medicare is the biggest player, right? I think 87% of our patients right now or something are under the waiver, and are through Medicare. So I think there's two things that are going on there. I'm very confident in the future of programs like this. There has been an extension, and we've had enough patients come through now. There's good data to show outcomes on cost, outcomes. Patients love it. The patient satisfaction scores are really good in these types of places. I think that ultimately it's a matter of working with our lawmakers and public policy to try to keep sustainment on this. So we're not just kicking the can down the road over and over. We're no longer in the public health emergency. So it's time to sort of say, hey, what have we learned? We went through this thing. What can we actually do to make this sustainable going forward? At the same time, we're also going to be diversifying some of the things that are going on in terms of talking to other payers, right? Yeah, Medicare's the biggest one, but they're not the only one. And there are other people who are willing to engage in this, especially as we get data and good outcomes and all the analytics that come with it. I mean, 550 patients through the system in a year and a half, that's a good end to start looking at what happens here and what's the cost and so on. So those are also conversations that we can continue to have with other payer partners as well.
Yeah, great to hear that. Thanks for sharing that perspective. And Rachel, good to have you back. So a quick question for you. So I'm curious, as Bioformis, like you said, it's a singular platform that enables remote delivery of acute care, transitional, and even chronic disease management. So given all this, I'm curious, what trends are you seeing in these areas for some new programs?
Yeah, well, it's funny that you bring that up, because when you're bridging the whole spectrum, you do tend to see the trends, and there's a bit of a wave going on. I think health systems are starting to learn that hospital at home alone isn't enough to cover their needs. It's an impact, small impact.
Oh, looks like we lost her again. I think she might be having some internet issues. So why don't we jump back to Daryl?
Manage their patient needs and manage their patient flow. So the trends that we're seeing.
Yep. I think you cut out for a second there, Rachel. So why don't I jump to I can jump to Daryl for a second. So Daryl, sometimes we hear the phrase that the most dangerous thing that you can do for a patient is to discharge them. So does Christiana have a post-discharge remote care program or any plans for a program? And without this pay parity of the hospital at home waiver, why do you think more and more health systems are starting to stand up these programs?
Yep, absolutely we do. We have something we call our Boost team. It's a referral-based team that when folks are being discharged, they help with discharge planning, continuum of care, and they really kind of take the patient from that post-discharge space right through that 30 days with follow-up visits and things like that. These are hospitalists who are continuing just to follow up on the patient and to interact with them in those ways. And actually, it works out really well for our post-hospital care at home program patients because the handoff is oftentimes to the same physician group. So we're following up on them in a continuum of care with people who really understand the patient, understand where they're at.
Mm-hmm. Great, thank you for sharing that. And so Adam, same question to you. What about WellSpan? Where does a post-discharge remote care program fit into WellSpan's overall strategy?
For us at WellSpan, it's on the top list of our strategic plan moving forward into the next fiscal year. The biggest thing we want to do is improve and enhance. So improve capabilities of monitoring that we can do at home, enhance our services, and ultimately we want to be creating access for our patients. So discharge planning from a hospital, what we're working towards is RPM is considered for every patient. Discharge disposition is home. Do they need RPM? And also incorporating it with our home health. Our home health patients only get 2 to 3 nurse visits per week, but this will provide them, 7-day-a-week registered nurse access and care team access. Incorporating more social determinants of health. The patients with social determinants of health are known in published literature to have access issues. So this team of registered nurses behind our scenes are not just clinical, they're also working as a social worker and care managers and connecting the dots to the DME suppliers, really a one-stop shop for the individuals on our service.
Great, thank you, Adam. Still waiting to see if Rachel is back. But in the meantime,
I am dialed in, Jen.
Okay, great. Good to hear you, Rachel. So why don't we go back to that question that you were answering, because I don't think we fully heard your response. So I'll just restate the question for you and the audience. So as you mentioned, Bioformis is a singular platform that enables remote delivery of acute care, transitional care, and chronic disease management. So we're curious to hear what trends you have been seeing for each of these programs.
Excellent, thank you. And I'm not sure what you heard already, so sorry if it's repetitious, but what we're seeing, because we cover the whole care continuum, we're able to see where things are waxing and waning in the market. And where it used to be a health system would choose one option and sort of stick with that to try to be the total solution, what they're finding now is that, in fact, they can start in one area, choose hospital at home or post-acute as a starting point, but really in order to fulfill all of the needs of the health system as far as hospitalization, rehospitalization, length of stay, throughput, et cetera, they need to build up these additional programs, eventually covering the entire care continuum. And so where hospital at home kind of came in hot during the COVID crisis, everyone needed a hospital at home. That's simmered down a little bit, and there's a heavier focus on the post-acute and certainly the chronic, but ultimately covering that entire care continuum.
Great, thank you for sharing that. And then Rachel, another question for you now that we have you back and we can hear you clearly. So as you said, as we shift from hospital at home to remote care following discharge, what features, functionality, and services do you think are most important to monitor and care for patients over a longer period than the 4 to 7 day span of acute care?
Yeah, as you can imagine, during that acute hospitalization, patients are really willing to do anything because they're frightened, they're ill, and they'll bend over backwards to meet the needs of monitoring. But as they start to feel better over time, the tools need to really support that patient's health status. And so if you're thinking continuous monitoring during a hospital at home stay, then you need to think episodic monitoring or a tapering off of continuous to episodic monitoring as the patient improves, both for compliance and because as they improve, they should be more independent and not need that continuous monitoring. Additionally, in-home services are a heavy need when patients are now not getting daily visits from twice-a-day visits from nurses and virtual visits from providers. And so you'll need to have a wide selection of clinical services that can go in the home as needed to ensure that that patient isn't rehospitalized. And of course, plugging Bioformis, as you know, we supply all of that in-home service as well as the platform to manage those teams and really coordinate efforts.
Yeah, great insights there. Thank you, Rachel. And so turning it back to Adam and Daryl. So Adam, with the success that your program has achieved so far to date, what would you say is next? Scaling up the average daily census, is that a goal? What guidance would you give other programs looking to grow their programs?
The past 6 years, spending time in this space and learning, there's been a lot of great success. Scaling is always, I think, at the forefront of every organization who has a remote patient monitoring program, but it's really how we scale that and what we're focusing on. So for me, it's broadening the patients we're serving. So how can remote patient monitoring services be incorporated into our palliative population for symptom management? How can we create remote patient monitoring for a mental health crisis that we're facing in Pennsylvania, not being able to get patients, providers and the mental health services they need? So just kind of expanding a little bit beyond the medical side of the patient that everybody thinks about in the remote patient monitoring space, and trying to be all inclusive of all of the patients and delivering healthcare services across the care continuum in our community space. Recommendations. This is a standard of care that it needs to be considered for every patient, whether they're at their PCP, specialty practice, or if they're in the hospital. What we've learned is it needs to not have a human connection or a human, muscle memory to remember. It needs to be embedded into your EHR. So there needs to be triggers based on diagnoses, social determinants of health, ED, hospital utilization, access issues, stuff like that would trigger this to populate and generate as an order for time of discharge or as a care gap in the ambulatory space or a BPA. There has to be that drive behind the EHR that's going to launch this forward. Because at the end of the day, no human's going to remember every resource that we have available, unless you're one of us, of course, who live, eat, and breathe in this space.
Mm-hmm. Great. Thank you, Adam. And Daryl, similar question to you. So what's next for Christiana Care? I know you mentioned doubling the census. And like Adam, what other advice would you give to some of these remote care programs?
Yeah, I think the continuum of care conversation will be one that people will be having for the foreseeable future. We have the bookends right now in the Center for Virtual Health that I work in. We've got primary care, and then we've got all the way over to acute, and it's sort of like what happens in the space between. You've got chronic disease management, but also how do we support home health aides? How do we support people who need higher levels of subacute care? And more continuous monitoring. And how do we do that without having to buy or resource a solution for every single level? How can we reuse, we build it once and use it many is really that's the place where this ends up being really important. I think that we tend to look at these problems as being clinical problems or being sort of engineering problems, but we really, I think, need some economists to help us in some of these spaces as well. Because so much of this is about the alignment of incentives between the various, pieces of the health system, or really payers and providers and patients. They all have to align, and they all have to be getting what they need out of the proposition in order for it to really be sustainable. We can create all kinds of amazing, sort of back-end logistics. But then if the technology on the front end of the patient is so clunky, it doesn't really fit into their lives, they'll sort of, put it in a box and never take it out again, right? They're going to be very resistant to that. Payers have to be aligned to the idea of paying for these things and reimbursing. And then the providers have to change their workflows, and they've got to put capital investment into their IT systems and align all those things. So there's a lot of moving parts that have to do more with economics than have to do with actual, like the engineering. Engineering is actually It's complicated, but it's probably the simplest part of this entire thing because these technologies already exist. They're just not lined up in a line the way we need to have them for complete delivery.
Yeah, definitely. Yeah, alignment of incentives, 100%. And yeah, a technology is, we can have all these fancy technologies with all these fancy algorithms, but a technology is only as good as how easy it is to use, right? Is it actually something that the clinician and the patient can use one time and not have any issues? Thank you. And then Rachel, another question for you. So I think when you were gone, I was speaking to Adam and Daryl about some of their new post-discharge programs and how that fits into their overall strategy. So I'm curious. So with many other health systems starting to look at this model and piloting these post-discharge remote care programs, is there a recent patient story or use case that comes to mind that typifies the value that remote care can deliver, both to the patient and the health system?
Yeah, can you hear me okay?
Yes.
Okay, good. So of course I have hundreds of stories that I would love to share, but to nail it down and give you one succinct story, and it's one that we've had similar versions of several times, so I think it'll nail home with the team here. Patients discharged after a heart failure exacerbation. They had multiple comorbidities. This is not their first acute on chronic exacerbation. And so they're sent home and they're being monitored by Bioformis for a few days, and they begin to have issues. The weight goes up. We have the one patient scenario that I pulled up, referencing this would be 4 pounds in 48 hours. Okay, so that's concerning. We get a notification. We reach out to the patient. They, of course, are symptomatic with 4 pounds in 48 hours. And our clinicians intervene. We get them on, increased dose of Lasix for the next 3 days. Weight comes back down to dry weight. And we, in the Bioformis world, we like to communicate and collaborate. And so we'll communicate our interactions with the cardiologist. Cardiologist was happy with our interventions, and the patient avoided that hospitalization or rehospitalization, as the case may be. We see that story and versions of it. Dozens and dozens of patients with that exact same scenario. Heart failure exacerbation, sent home for whatever reason. They return to their high sodium diet. They don't do their fluid restriction. Whatever it is that triggers them, back up the weight goes, and they revolve door right back to the hospital. But we are able to intervene and keep them at home again and again. So that's a fair, good one for everyone to chew on.
Great. Thank you for sharing that, Rachel. Okay, so I think now we will move on to the Q&A. So as a reminder for everyone watching, please submit your questions using the Q&A tab, which should be to the left of your screen. So it looks like we have a lot of questions, a lot of great questions already. So we will try to get to as many as possible. And if we don't get to all of them, we will try to follow up with everyone who submitted personally after the webinar. So, okay, why don't we start with this one, and I'll just let anyone answer this who would like to answer it. So artificial intelligence is obviously everywhere these days, but is it something that you see as applicable to remote care and hospital at home specifically? And how do you see AI being an enabler to improve patient and provider experience?
Unless anyone feels strongly, I can jump in.
There's actually two different sort of types of AI that immediately come to mind in this space. We've all, seen the generative AI and ChatGPT sort of examples, and there's some amazing things being done. You go to any trade show, and people strap you in, and you'll talk to an AI, and it will converse with you like it's a person. So there is a patient-facing component to AI, I think, that's going to become more and more dominant, or especially for administrative or very straightforward types of tasks. The first, stop, much like you might chat with your favorite online retailer to get a refund, and it takes 2 seconds, and you never talk to a human. I need another blanket or something like that. Could very easily be handled by an AI that's patient-facing. I think more in the clinical space, there's going to be a lot more conversation around AI escalating. Who do we need to look at as we try to scale workforce to cover this? If you're going to an ADC of 25 or 50 or 100, how many personnel do you actually need to be monitoring that? And to what degree can AI tell you that this person is in need of more attention or less attention because you're not putting eyes on them? Doing rounds and so on and so forth. Now we are videoing and so on, but there's a lot that goes into saying I need to understand how all of my patients are doing all of the time, especially in that acute space. And then what do we need to do to intervene and escalate? So there's a lot of potential for AI. It's super exciting in this space, and it'll be really interesting to see over the next year or two what really comes out.
And Jen, you
Thank
may
you,
or may
Jen.
not know this is something that we feel very passionately about at Bioformis. AI is our name and our game. So branching off what Daryl just said, we've already started to dive into how our AI can drive the clinician's eyes to the right patient at the right time, really bringing patient-specific baselines into the scenario, building that patient-specific baseline, and then alerting our clinical teams when they've deviated from their own baseline, as opposed to traditional static thresholds that don't necessarily cover that patient. So every patient doesn't have the same baseline, and so that type of AI, and then building even further from there to patient-specific, disease-specific algorithms. That again, that AI will drive the clinician to the right patient at the right time.
And Rachel, I'm glad you brought that up because that's exactly where my mind is, and I'm partially on the clinical side more so than the operations side, but really how can we use AI to drive clinical operations? How can we decrease alarm fatigue? How can we help our clinical nursing and provider staff focus on the patients who are the highest priority and then work your way down?
Great, thank you all for those perspectives. So another question that we have from the audience. So the EHR companies, they hold many of the keys to the patient data castle. For remote care programs, how big of an obstacle is integration? And where do you see opportunities if a program deploys without initially doing a complete bidirectional integration with the EHR?
I would say at WellSpan, it has not really been an obstacle. We have a very strong IT team that thinks outside the box. For example, for our hospital at home program, it was a customized inpatient outpatient hybrid build that they presented at multiple EPIC conferences on how they leveraged what we're capable of doing in the EHR. So it looks like the patient's in the hospital, but they're in the ambulatory space and things are functioning, firing in the background. For remote patient monitoring, I think the key is if it's out of sight, it's out of mind. So it needs to be part of the daily flow of your provider team. So if you want that cardiologist, that PCP, that pulmonologist to engage in referrals, they need to know what they're getting out of it. So when they see a patient for a follow-up, they want to be able to see right in front of you, this patient's on remote patient monitoring, this is what they've been doing, really hitting you in the face with that information. Some programs in the past have been very tucked away in our EHR system that you have to give a 2-page diagram of how to access the vital signs, and that's just not going to create buy-in, and it's just not going to create value.
Great. Any other comments on that question?
Well, I'll just add that we've had. Oops, sorry, Daryl. I think I have a little delay. I apologize. I'll just add that we've had many successful implementations without EHR integrations. It's not a requirement; it is a luxury in many cases, and so it's really just a matter of building out communication and workflow tools that circumvent the need for that EHR integration, or you can do different levels of EHR integration to make it a successful program launch.
Mm-hmm.
Yeah, and that's exactly what I was going to say. We actually launched our program without full integration. We have outbounding of some orders and things like that and demographics, but we really didn't have full bidirectional capabilities to start with. And, that may be capabilities and functionality we'll build as we go forward and as we scale the program, but for a minimum viable product, we didn't need it to start. And it was more important to start and kind of see what you need than it is to try to build the perfect machine and wait for, a long time to to get that first patient into the program.
Great, thank you all. What impact is the uncertainty around the future of reimbursement having on the growth of new remote care programs across the U.S.? Would anyone like to tackle that question?
I think there's a sense of inevitability to it right now. I think people are just growing the programs because they know that this is the future, and we're extremely committed to that at Christiana Care. We know that this is the right thing to do. It's going to provide the ability to scale programs to get better outcomes. And we know that as we do those things, it's going to get the interest of payers, and reimbursement is going to follow. The waiver obviously was huge, and the heavy lift in getting some of these things off the ground. But as we move forward, I believe that if you build it, they will come. And I believe that that's really what the future holds for these types of programs.
Mm-hmm.
We at WellSpan are currently billing for remote patient monitoring services, and that was quite an interpretation and task to implement. And then even after the PHE, there was, because like I mentioned before, we're established under a practice, so our providers, in order to bill, have to now establish a relationship with a patient. But it just forced us to create a care model where we're a specialty practice now caring for our patients under the remote patient monitoring space. But part of the biggest build to the billing for us was to make sure we had a live copay estimator tool when the referrals came in, so we can provide that information to our patients. We're not seeing a alarmingly high level of copay, but there are patients who are resistant to paying copays right now for this service. And I believe, as Daryl was saying, I think our payers will continue to evolve because there's a lot more value behind this than creating financial barriers to our patients.
Yeah, I echo that. If you build it, they will come remark, Daryl, because that's what we're seeing, is that as we are building these programs and talking to payers about how they're going to reimburse, really they're looking for outcomes. And so this next few years really is like a test run to see, can we improve the outcomes of the patients? Can we show those outcome improvements? And if so, they'll create the codes to reimburse because they want the improved outcome. So agree 100%.
Great, thank you. Great insights. So next question, how important is partnering with a company that can adjust the level of service that they provide over time, i.e. not making the solution an all or nothing proposition?
So I take that question as, how important is it to partner with a company that will think outside the box? And I think that's very, very important if we want to remain competitive. I always tell people, as a nurse practitioner, there's no COPD patient, there's no heart failure patient, there's no two alike. Everyone's different. So when we're monitoring these patients at home, they shouldn't have to be measured and monitored the exact same way because they had a diagnosis that was the same. Each one has different normal biometrics, normal vital signs, normal thresholds in their chronic care management. So really pairing with a company that's going to think outside the box with you to deliver the best care for your patients will only be reflected in the outcomes and the care we provide.
I appreciate that.
Rachel and I are on the same cycle here. Go ahead, Rachel.
I was just going to say I appreciate that perspective. As a provider of those services, it's interesting to hear how important it is to be flexible. And we are almost so flexible that we'll provide clinical services as needed or not. We'll provide technical services as needed or not, logistics. Really, we try to flex our programs to meet the needs of our health systems. So it's interesting to hear how that's another layer of flexibility that you're looking for that is not even just diagnosis specific, but patient specific.
Yeah, I completely agree with that. And I would add to it that it's interesting to say, how important is it to have a partner that's modular? That's important to say, hey, I want this part, I want an acute care program, but I don't need, chronic care monitoring yet. But it's also important to have partners that have platforms that can have those capabilities. What we have seen a lot in the road here is that we're kind of buying this solution and that solution and the other one, and they all have integration costs, and they all have back-end costs, and they all have maintenance, and the cost on all of them goes up year over year. And so to have a partner to say, there's a roadmap, and we can get there from here, and we can buy it a piece at a time, but all the pieces are there. Both are equally important from our perspective.
And I think just the dovetail, having that partnership with that company that wants to continue to evolve. So I know Bioformis on multiple occasions has said, if you have an idea, come to us. We'll work together. We'll pilot together. We'll figure out something together. In this space, we need to remain innovative. And I think the pandemic forced us to do that. There were some companies who did and some companies who did not.
Yeah, I would just echo everything that you guys have been saying. I know in my experience at MGH Home Hospital, when we were first starting out, a lot of this technology was more technology that was designed for the chronic care setting, and then maybe remarketed to the acute care setting. But it was still really the same technology. But now, after being an advisor in this space for a while, it's been really exciting to see this trend change, and that this theme of not having the perfect solution for a home hospital, it is changing as vendors are starting to really specifically design for that use case and that continuum of care. So great to see that innovation and all of that moving. All right, another great question from the audience here. So many patients who can most benefit from remote care are also often the least tech savvy. So can we mitigate how a patient's tech literacy determines the success of a remote care program?
I personally feel, through surveys of some of our programs about the technical side of our programs, that pre and post pandemic, we've seen a huge shift between adoption of technology. I think ease or feasibility of some of our devices ranged almost 50% pre-pandemic, and they're upwards of 90% now post-pandemic. I think the pandemic really helped us. You had to go out to, if you were going out to a restaurant to eat, you were going to scan a QR code, you were going to maybe order from a kiosk or DoorDash apps on your phone, virtual connections with your PCP, kind of forced us, dragging us into the future that we needed. I think a lot of the technology that's available today is pretty user-friendly. I remember my first iPhone that didn't come with instructions and said, just turn it on. And I'm like, I don't understand how that's going to work. But it is really that easy, and has become that easy where you're really turning it on. It's prompting you. And then at WellSpan, we have support. So if you're under our home health services, a nurse can assist you with doing this in the event that you do. If you're obtaining this device from a PCP office, we'll open it up, we'll crack open that case and get you started before you go. So we do have mechanisms of backup in play. We can do video visits with our RN care team, and they can walk you through. And then I know Bioformis, for example, has technical support as well. So I think we've evolved immensely in this space to create a very easy technological experience for our patients.
Yeah, I would echo that, and to say that it's only getting easier. I mean, when you look at things like photoplethysmography, off patient type, observation that you can do, and some of the accuracy that's coming out of that, I think we're getting more and more savvy about not requiring a huge, you take it out of the box and it just works. You put on the patch and it just does its thing. There's not a lot to think about. I referenced, we need some economists. We probably also need some estheticians, to really, the Apple style, hey, this is super easy. This looks cool. I'm happy to use it. It's part of my lifestyle brand. Some of those types of things really are going to be impactful as well.
Yeah, I know that's been a lot as well. Sorry, go ahead, Rachel.
That's okay. I was just going to layer in there that with all the knowledge and all the advertising that's going around with technology, and as that older population ages out, the seniors or those that are typically less savvy with technology are becoming more comfortable with it. And my 83-year-old father uses an iPhone like it's nothing. So I think there's less of that issue. It's becoming less of a problem as more physician offices and health systems are using technology, patients are becoming more tech savvy, just by the nature of seeing it and being around it and being familiar with it.
Yeah, definitely. Yeah, I know our motto at HTL and Home Hospital is just, it's all about minimizing the maze to the digital front door, right? Making it work right out of the box. Like no clicks, no button clicks, it just works. I know something that's worked well for our program is for the virtual visits, our tablet is designed so that the clinician can just beam onto the screen so that the patient doesn't have to do anything. There is, of course, a privacy cover that the patient can decide to use. But yeah, we found, anything and everything to just reduce button clicks, reduce setup. All right, a question for Rachel specifically. How do you manage the handoff between the hospital clinic team to the post-acute clinical team to the primary care team?
Yeah, that's an excellent question. It was a challenge initially. It starts at implementation. And so we do some networking in the beginning to let everybody know that there's going to be this patient transition. And we'll do so through messaging through the EMR is our best way. Letting them know that the patient has been enrolled in this post-acute program, these are the goals of the program, and this is how we'll transition. And then again, transitioning to the PCP, the patient has completed their program, they're now moving into the chronic care program, and these are the goals of the program, and these are the actions that we'll take. So the handoff, typically it's an electronic communication, like an e-fax or EMR to EMR. In some cases, we will do actual phone calls, depending on the savvy approach of that care provider. Not everybody is into e-faxes, and not everyone communicates well that way. So we try to tailor the communication to the expectation of the receiving provider.
Great, thank you, Rachel. All right, another question for everyone. So what have been the panelists' experience with getting adoption by internal stakeholders? In other words, if you build it, will the referrals come? And how do you win over skeptics? How do you win over the hospitalists that are unsure about referring patients?
Well, that's a very loaded question with multiple layers of multiple layers in there. So the biggest thing, so I can reflect on building the hospital at home program. With my boss, it started out as an idea. He was recruiting me from our previous work in the hospital. It's really bringing those stakeholders together at a table and giving them all a voice. We don't want to designate operations to different departments. I mean, this was 7 or 8 departments coming together for hospital at home to make it seem seamless from the patient perspective side, which we accomplished, but we had to have them all there. But we had to actually have people who were doing the work there as well, and not just people who supported those departments and were in the operations. I think that was one key. As a hospitalist, my colleagues were very skeptical when we launched some of these programs. I think they were less skeptical because they would work with me, and I was now presenting this for the post-acute side. But data is going to decrease their skepticism. So you're going to have to launch, you're going to have to run tight operations, great clinical and quality outcomes, and rush that back and say, hey, it's working. What other barriers do I need to knock down for you now?
100% on the data. I mean, you show the outcomes, you show how the patients appreciate it, and you show that the person is not falling into sort of a black hole, right? The patient is going to hospital care at home, which is still connected to the system. If they need escalation, explaining what that path is to get back into the inpatient, bricks and mortar space, how the follow-up is going to happen, I feel like there's a lot more comfort level once that sort of gets explained, described, and people start to see, oh, this is really actually working. But you have to kind of just be a little bold and start in order to get the data that you need to prove that it's working.
And a good way to do that is often to do either a run-in phase or a soft to launch, right? Let them get accustomed to it before you're fully rolling it out. Maybe do either provider group by provider group or floor by floor, whatever your slow roll is. If you have somebody who's a little bit less skeptical, you start with them and then build from there. So all that to say, I think, you can win over the skeptics. It will take time. You have to, advertise and promote the program. To the other panelists' points, data is everything. Data is king. So if you have the data, use the data. If you need the data, find the data and present it. But you'll win them over in the end.
Yeah, great insights for that loaded question. Thank you. All right, so we have time for a few more questions here. Okay, so here's one. Who within your leadership at your hospital was key in starting and sustaining a program? I recently saw something about the California Nurses Union having concerns about remote care. Are there blockers, and do they have valid concerns?
Maybe I'll jump in on the union as the nurse in the room. So the union concerns in California were really around the role, and is there a role in the union, or will it need a non-union nurse to come in and take over? And so that's an arrangement that can happen between the hospital and their union nurses, whether they create a role or they bring in outside work until they do create a role. But within the leadership at the hospital, it really takes somebody from each department. You need your chief nursing officer, your chief medical officer. You need your CFO and your CMO, or COO. Everybody needs to be on board in order for this to be effective, because it touches every department. Once you get every department involved, then the concerns or barriers to remote care are, refer back to the previous question. They're something that can be overcome in time.
I would completely agree with that, and I think involving people at those levels is also important, because when you start a new program like this, it is costly. There are startup costs, and it will not make money out of the gate. So there has to be some commitment to run it for a while, to let it kind of catch up and mature and become all of the things that it needs to become. So there needs to be commitment at all those players, and we actually created a chief virtual health officer role specifically to sort of shepherd this process and to be a voice in the room to say, this is the person who advocates for these kinds of programs. And we found that to be really important as that, became a reality.
To echo a little bit what Rachel was saying, I think nursing, as we ebb and flow with our patient conditions on a daily basis, and we can wear 13 hats, when it comes to the foundation of nursing, I think sometimes we're a little resistant to change. As weird as that may sound, my patient could change 5 times in a shift, and I'm fine with it, but the foundations of my career change, from the fact that I have to badge access in versus type of password, could throw somebody into a spiral. I think there's also the fear that, will nurses be replaced with technology? And I don't think that is ever realistically able to happen. But as we advance into one of the worst nursing shortage crisis that we're going to have, we have to start thinking, how can we leverage other ways to deliver nursing care? One thing we're getting ready to launch at WellSpan is, in our inpatient unit, we're going to pilot how can we have virtual nurses assisting those bedside nurses with day-to-day tasks, discharge education, communication, call bells, etc. Because at the end of the day, we're not going to have enough bodies.
Great, thank you all. So I think that is all the time that we have for questions. We did have a number of other questions that we didn't get a chance to get to, but we will try our best to get back to everyone who submitted personally after the webinar. So now I will hand it back to Joan to close us out.
Thank you for attending this Fierce Healthcare webinar. I'd like to especially thank our speakers for presenting and Bioformis for presenting today's webinar. With a connected technology platform, Bioformis partners with health systems and risk-bearing organizations to revolutionize the delivery of remote care at home across the continuum. Bioformis is bringing the right care to everyone, everywhere. For more information about remote care at-home solutions, please visit bioformis.com to learn more. A recorded version of this webinar will be available to you to access within 24 hours using the exact same audience link that you used to join today. Thank you again for being here. We look forward to seeing you again soon.